Welcome to this Step 3 clinical knowledge review on psychiatric emergencies in the emergency department, brought to you by Roadmap to Residency. These questions feel high pressure, but they reward a calm, ordered approach far more than memorization. Today, we will break down how the boards build stems around suicidal patients, psychosis, agitation, and the decision to hold or admit, and how to pick the right next step quickly and confidently. Our goal is not to reteach all of psychiatry, it is to train your eye to spot the pattern and apply a rule. Before or alongside this video, review the psychiatry and emergency medicine sections of your major review books and a good question bank so the foundation is already there. Here is our plan. First, we will learn to recognize the high-yield question stems for suicidal ideation and for acute psychosis and severe agitation. Then we will apply test-taking strategies to the criteria for an involuntary hold and to the choice between psychiatric consultation and inpatient admission. Finally, we will master the next best step format that the boards favor for the agitated, psychotic, or suicidal patient. Throughout, keep your review books and question bank closed because this video teaches you how to use that knowledge on exam day, not how to replace it. Our first strategy is the one that quietly decides many of these questions. Safety and medical causes come first. Before you ever label a patient as purely psychiatric, the boards want you to make sure the behavior is not coming from a medical problem or a substance. So when a STEM hands you abnormal vital signs, a fever, disorientation to time and place, a level of alertness that drifts up and down, or vivid visual hallucinations, your answer should lean toward a medical workup, not a psychiatric label. A sudden change in an older patient is delirium until proven otherwise. Once medical causes are handled, the order is simple. Make the situation safe, then assess the risk. For an agitated patient, the right first move is almost always calm verbal de-escalation in a quiet, low-stimulation space. Reach for medication or restraint only after de-escalation has truly failed, because the exam always rewards the least restrictive option that still keeps everyone safe. Strategy 2 is reading the suicide risk picture, because these stems love to test whether you can tell high risk from low risk. The features that raise concern are a specific plan, access to a method, a prior attempt, recent loss, and a strong sense of hopelessness. Older age, male sex, and living alone push the risk higher as well. But the single most decisive clue in any STEM is a specific plan paired with the intent and the means to carry it out. Here is the trap to watch for. The real question the board is asking is whether this patient can safely leave, and a patient with active intent, a plan, and the means cannot be discharged even when they suddenly say they feel fine and ask to go. And remember, asking directly about suicide does not plant the idea, so the right answer almost always includes asking about it plainly rather than tiptoeing around it. Now let us train on STEM recognition. There are 3 patterns you will see again and again. The first is acute psychosis, a young adult with hallucinations, disorganized speech, and paranoia who is alert with normal vital signs. You assess safety first, then favor a calm setting and an antipsychotic, and the normal vital signs steer you away from a medical cause. The second is severe agitation, a patient who is a danger to self or staff and who has already failed calm talking. That patient needs medication, usually an antipsychotic, sometimes with a benzodiazepine, and physical restraint is the last resort that must be reassessed often. The third is the suicidal patient who voices a specific plan with intent and access to a method. That patient needs constant observation, a safe room with dangerous objects removed, and urgent psychiatric evaluation, and cannot be left alone or sent home. Active intent with a plan is the phrase that locks in admission, so circle it every time. Let us work through our first practice question. A 40-year-old man is brought to the emergency department after telling his wife he intends to end his life with a firearm he keeps at home. He is alert with normal vital signs. Now, sitting in front of you, he says he feels fine, regrets bringing it up, and demands to be discharged. The key detail is that he still owns the firearm and can describe exactly how he would use it. The question asks for the most appropriate next step. Take a moment to notice the 2 facts that matter most. He has a specific plan with the means, and his sudden calm does not change that. Think about what those facts force you to do before you look at the choices. Let us break this down step by step. Step 1, spot the pattern. He has a specific suicide plan, stated intent, and ready access to a firearm. and his sudden calm and wish to leave do not erase that. The active plan with the means is the loudest signal in the stem. Step 2. Apply the rule. A patient with active intent, a plan, and the means cannot be allowed to leave. So the answer is to place him on a hold for safety and arrange urgent psychiatric evaluation, choice B. Safety comes before his request to go. Step 3. Eliminate the wrong answers. Choice A is wrong because a recanted statement does not remove a concrete plan and the means to act. Choice C is wrong because a no-harm agreement does not keep a high-risk patient safe. Choice D delays the protection he needs right now. The answer is B. Here is our second practice question. A 25-year-old man with a known psychotic disorder is brought in shouting, pacing, and swinging at staff. His vital signs are normal and there is no sign of a medical cause. The staff have already spoken to him calmly and offered him a quiet space, but he keeps threatening the people around him. The question asks for the most appropriate next step in management. As you read the choices, hold on to 3 details. He has failed calm verbal de-escalation. He is an active danger to staff, and his vital signs are normal with no medical cause. Those details are pointing you toward one specific next move. Let us work through this answer. First, read the question carefully. We have a patient with a psychotic disorder, normal vital signs, no medical cause, and continued violent threats even after staff tried calm talking and a quiet space. That tells you de-escalation has already failed and he remains a danger to the people around him. Now, why does medication win? Because when verbal methods fail and the patient is dangerous, the next step is medication to bring the agitation down, so an antipsychotic is the answer. Choice B. Continuing to talk alone ignores the danger right in front of you, jumping straight to 4-point restraint as the very first action skips the less restrictive medication step and is reserved for when nothing else works. Discharging a dangerous patient is plainly unsafe. The answer is choice B. Let us talk about involuntary holds and admission, because the boards quietly test your judgment here. A hold against the patient's will is justified only when specific criteria are met. The person is a danger to themselves, a danger to others, or so gravely disabled by a mental illness that they cannot meet their own basic needs. The guiding rule is to choose the least restrictive option that still keeps everyone safe, and a hold is a time-limited measure that triggers a prompt psychiatric evaluation. Now, when do you consult versus admit? Obtain psychiatric consultation when the diagnosis or the safe disposition is unclear and you need a specialist's judgment. Move to inpatient admission when the patient is still an active danger to self or others, cannot be kept safe as an outpatient, or needs supervised stabilization. In short, an unsafe patient is admitted, while a stabilized, lower-risk patient can often be managed with consultation and close follow-up. Here is our third practice question. A 30-year-old woman with severe depression is brought in after a deliberate overdose. She is now medically stable, but she tells you she still wishes she were dead and would try again. She refuses admission and asks to sign out against medical advice. Importantly, there is no medical reason she must stay for the overdose itself. The question asks for the most appropriate next step. As you weigh the choices, notice 2 things. She is medically cleared, but her ongoing intent to die makes her an active danger to herself, and her refusal to stay does not make her safe to leave. Let us break down this answer. A recent deliberate overdose with an ongoing wish to die is an active danger to self. Yes, she is medically stable from the overdose, but her stated intent to try again is the decisive fact in this stem, and her refusal to stay does not make her safe. So the answer is to place her on an involuntary hold and admit her for psychiatric care, choice B. Letting her sign out against medical advice ignores the very real ongoing risk. Handing her a crisis hotline number does nothing to keep a high-risk patient safe tonight. Asking a family member to watch her at home is not adequate supervision for active suicidal intent. When a patient remains a danger to themselves and refuses care, you hold and admit. The answer is B. Here is a high-yield test-taking pearl on psychiatric emergencies. Learn to separate a medical cause from a primary psychiatric one by the clues in the stem. A medical cause is suggested by abnormal vital signs, a fever, disorientation, a level of alertness that drifts up and down, visual hallucinations, or a sudden change in an older patient, and it should send you toward a medical workup. A primary psychiatric picture tends to show normal vital signs, clear alertness, and hallucinations that are more often heard than seen. Match the clues to the category and the next step follows on its own. 2 reflexes will carry you through the management questions. First, ensure immediate safety and rule out a medical cause before you settle on a psychiatric explanation. Second, when a patient is an active danger to self or others, they cannot be discharged, and an involuntary hold with admission is the safe answer. That wraps up our psychiatric emergency test-taking strategies for Step 3. Remember the through line: make the situation safe and rule out a medical cause before you settle on a psychiatric label. Let active intent with a plan steer you toward a hold and admission, and choose the least restrictive option that still keeps everyone safe. For deeper study, review the psychiatry and emergency medicine chapters in your major review books and your question bank, and drill suicide risk assessment, the management of psychosis and agitation, the criteria for an involuntary hold, and the choice between consultation and admission. If this helped you, please like and subscribe so more students can find it. And when you are ready for one-on-one guidance, visit roadmaptoresidency.com to work with our expert tutors and residency advisors. Good luck on your exam, and we will see you in the next video.